Okay, let's learn about user bleeding today. Okay, what is user bleeding and how to manage user bleeding in emergency department? Okay, first of all, what is user bleeding? User bleeding or upper GI bleeding is a bleeding that comes proximal to ligament of fringe. If there is any sort of bleeding above or proximal to ligament of fringe, then that's called UGI bleeding. Common causes of UGI bleeding can be peptic ulcer disease, peptic ulcer disease, varices, esophageal varices, malarial erosive gastritis, malignancy, angiodysplasia. After this, let's learn about how to do initial assessment and resuscitation of the patient. Okay, resuscitation of the patient with UGI bleeding. First of all, we'll do airway breathing and circulation check. Okay, if we need to protect the airway, then we should intubate the patient. Okay, sometimes there can be blood, clotted blood, something like that, secretion of the patient. If the patient uh, has altered sensorium, there can be foreign body dancers, all that thing can be clear. So we have to clear airway if needed. Okay, and if they are unable to maintain airway, or there is massive massive hematemesis, then we might need to intubate the patient. Okay, after that we look for oxygen. Okay, if it's less than 94%, then we'll supplement oxygen, and we have to secure IV line, possibly two wide bore IV cannula should be opened. And after that after that we have to send blood work. Okay, blood work blood works like CBC, coagulation profile, coa- coagulation profile. Okay, coagulation coagulation profile. Okay, and like PT, INR, BTCT, if available, APTT can be sent in this patient. We have to do renal function test, liver function test. Okay, and blood grouping and cross matching. Blood grouping and cross matching, and keep the patient in ECG monitoring if possible, and we monitor intake and output as well. Okay, and BP is also needed to be monitored. After that, after the blood work, if the report of the blood comes, like hemoglobin report, after arrival of the hemoglobin report, we will think about the transfusion strategy. Okay, transfusion strategy for all the patients presenting to our emergency department with UGI bleeding. We transfuse them only if their hemoglobin is less than 7 gram per deciliter to keep the target of more than 7. Okay, but in case of coronary artery disease, if the patient is in shock, or if there is ongoing bleeding, okay, ongoing hematemesis, then we should transfuse the patient if hemoglobin is less than 8 gram per deciliter. Okay, along with that, we have to know what to do. Should we keep fluid or not? For the patient with UGI bleeding, if we think the patient has variceal bleeding, we try to decrease the fluid resuscitation because it might again cause rebleeding. Okay, but if a patient is in shock, okay, hypovolemic shock, then we should keep fluid initially, but after arrival of the report of hemoglobin, we'll make a strategy to transfuse them. Okay, and for the medication that is used in user bleeding, this is one of the important topics. Okay, basically we give medication under this category: antibiotics, somatostatin analog, proton pump inhibitor. Okay, and sometimes we give prokinetic drug as well. Prokinetic drug like erythromycin. What about the antibiotic? If we are thinking about the patient with cirrhosis, okay, all cirrhotic patient should receive antibiotic prophylaxis to prevent spontaneous bacterial peritonitis, sepsis, or rebleeding. We give ceftriaxone 1 gram every 24 hours. Okay. After that, what about somatostatin analogs? Somatostatin analog like octreotide should be given at 50 micron bolus dose followed by 50 microgram per hour. Okay, and this is given this is given to decrease portal venous pressure and splanchnic blood flow. Okay, and if we are suspecting if there is suspected variceal bleeding is much important. But if we suspect like this a patient of cirrhosis, CLD, we also give octreotide. Okay, and after that, role of PPI like uh, pantoprazole 80 mg bolus dose followed by 8 mg per hour is a dose of pantoprazole given immediately, and this is given to increase gastric pH and stabilize the clot so that there won't be rebleeding. Okay, and what about the prokinetic drug like erythromycin? The prokinetic drug like erythromycin is given only if we are planning if we are planning to do use an endoscopy earlier and to make our stomach clear of any content, gastric content. Sometimes we give vitamin K, FFE, or even platelet concentrate, if there is deficiency of specific things, like if a patient is in warfarin and is bleeding, then we give vitamin K or sometimes FFE. If the patient is bleeding and there is severe deficiency of platelet, okay, there is platelet of 10,000, then we give platelet concentrate. Okay, these are the drugs we commonly use in usual bleeding, and the transfusion threshold and how we do initial assessment and resuscitation in a case of usual bleeding. After this, we should know how to risk stratify the patient. Okay, risk stratify the patient. If uh, risk stratification can be done according to GBC scoring. Okay, Glasgow-Blatchford scoring. Okay, if the score is less than 1, there is a very low risk of bleeding. We can discharge this patient from ER and plan for outpatient. Okay, outpatient uh, endoscopy later. If it's more than 3, then more than or equal to 3, we should admit the patient into urgent UGI endoscopy. Okay. After that, the main thing is how to monitor and what to monitor. We monitor BP, pulse, input and output, and to hemoglobin, PCB every 12 hours. And if there is transfusion threshold is met, then we transfuse the patient if needed. Okay, these are the things we need to do during initial assessment of a patient with UTI bleeding. Thank you.